Thank you so much, Dr. Shrikanta, and thank you so much, ISA Mumbai and SAMS, for giving me this opportunity to present my experience on this forum. I actually come from the prestigious Institute Lokmanya Tilak Medical Municipal College, which has the biggest trauma center in Mumbai. And it has truly enriched all the generations of not only anesthesiologists, surgeons, to be more confident and equipped with managing these trauma cases. So that's our little data. I'm not going into details of it. So around roughly 3,500 number of admissions we do have in our trauma ICU, which is a 14-bedded ICU. Out of that, roughly 1,800 patients presented last year. This is last year's audit. So they presented with head injury, and out of that, around say 550, 560 patients got operated, and rest of the patients required intensive ICU care. So let's just, before beginning the lecture, let us just focus on this slide with a very fresh example of our Deputy CM's sad demise. We know that trauma has this tri-model distribution of deaths. So we actually can't do anything about these immediate deaths. These are the patients who rarely reach to our hospital, and they rarely get any intervention rapidly. But there are significant number of patients which fall in this early category. This purple color represents that. And if we can see on x-axis, the time duration up to 4 hours, if they are treated properly, diagnosed in time, and intervention is done, ICU care is given properly, then these are the patients in whom we can have a good prognostic recovery. And out of these, if you can see, the epidural hematomas and subdural hematomas are the most commonest ones witnessed. Okay. So we have in trauma, we have a concept of golden hour, right? So golden hour is from the injury to hospital, if the time is very important. If correct intervention is received or the correct treatment is received, then the mortality and morbidity can be significantly reduced. So time is very important whenever you are dealing with any trauma patient. Role of anesthesiologist in these traumatic brain injuries can be actually varied. We can be involved in pre-hospital care, airway resuscitation as a trauma team member. We can give our services, anesthesia services within the operation theater or outside the OR whenever they are shifted in CT or MRI suits. And we can also be trauma intensive care specialist and pain physicians for these patients, because these are the patients who are going to require an extensive period of our care in a multidisciplinary manner. So objectives of this talk are, I will be covering etopathogenesis, different types of brain injuries, ATLS approach towards these injuries, general principles of management, mainly medical management, anesthesia management concerns, post-operative care, and a little bit about special population. So to define, it is a damage to brain resulting from external mechanical force, right? The direct impact, it may be rapid acceleration, deceleration injury, blast injury, penetrating injury, or projectile object. Etiology may be varied. So in Mumbai, in our trauma center, majority of the accidents are bike accidents, four-wheeler motorbike accidents, railway accidents, but we do keep getting patients of accidental falls, assaults, rarely blast injuries. And burns, we do have a separate ward for burns. Now, when we are understanding what is the etiology of traumatic brain injury, just by knowing the mode of injury, we can anticipate what all problems the patient may be facing. So let's see what is the mechanism of injury in these patients. It may be either penetrating or blunt injury. So the injury may be because of direct impact. It may be an acceleration, deceleration type of injury, or it may be a shockwave injury in case of blast injuries. There can also be a coup and counter coup mechanism wherein the impact happens and the injury happens exactly at the site of impact and on the opposite side of exactly on the opposite side of the impact. So before moving to pathophysiology, let us just quickly revise our physiology. We all know that there is a Monroe-Kelly doctrine which states that blood tissue, brain tissue, blood volume, and CSF volume, they are in a state of they are in a state of dynamic equilibrium, right? So increase in any of the compartment causes alteration in the two or more compartments. And if that doesn't happen, then it will lead to increase in ICP. So any trauma leading to accumulation of blood is going to alter the entire physiology inside the brain, right? Then we have to know what is the normal intracranial pressure, which is 5 to 15. Cerebral perfusion pressure, because this is very important in traumatic brain injury to maintain the cerebral perfusion pressure in order to avoid ischemia, infarction, and brain death. We all know that cerebral blood flow, it has a autoregulation range ranging from 50 to 150, right? So the cerebral vessels, they auto-regulate during this range, but beyond this range there is a complete decline or alteration in the cerebral blood flow. Also the CO2 also has a major impact. You can see on this green line on this graph, that CO2 also has a major impact on ICP, and it may lead to cerebral ischemia. Okay, so let's see our pathophysiology. Again, coming back to types of injury, the direct trauma leads to primary type of injury. Okay, the trauma happens and that leads to primary traumatic brain injury. But after effects of this trauma leads to activation of immune system, external insults, inflammation, all this gets amplified and it leads to secondary brain injury, and chronically immune mediated response leads to tertiary brain injury. So let's see in detail. Can we do anything about this primary brain injury? Actually, no. It happens at the time of accident, right? So this primary brain injury may lead to some contusions, a disruption of blood-brain barrier, hemorrhage, neuronal axonal injuries, and release of all the mediators of inflammation. After primary injury, there is a secondary brain injury, which actually is modifiable by our treatment. Anything leading to hypoxia, hypotension, hypercarbia, raise ICP, hyperthermia, acidosis, and infection, all this is going to impact the brain and cause further injury leading to secondary brain injury. So this is in our hand whenever, at whichever time zone we are seeing the patient, but avoiding secondary brain injury should be our objective whenever we are seeing these patients, right? And that is how, by handling this, we can minimize the insult and minimize the neurological deficits. Now let's see in detail. There are certain subtypes. So traumatic brain injury, it can be focal or it can be diffuse, right? So the focal injury can have some contusions. We can have hematomas, subepidural, subarachnoid, subdural, intraventricular and intracerebral bleeds may be there. There may be a penetrating injury because of gunshot or some iron rod, like that, sharp object. Or it can be a diffuse brain injury leading to concussion, diffuse axonal injury, and shock wave. We saw it earlier. Okay. We also can get a typical shaken baby syndrome. So diffuse injury in small babies, we do get such kind of cases. So let's see what are the different types of hematomas. So epidural hematomas, they are the ones what we have to remember. Depending upon the site, they have been classified. But as an anesthesiologist, we should remember that epidural hematomas are the ones which represent the arterial bleeds. So they can really expand very well, very fast. And subdural hematomas, these are mainly venous bleeds. So they have some time to develop. Subarachnoid hemorrhage and intracerebral hemorrhage. Depending upon the Glasgow Coma scale, these traumatic brain injuries can be classified as mild, moderate, and severe. Okay, so Severe ones are GCS score between 3 to 8 and mild ones are 13 to 15. Moderate and severe, this GCS sector actually requires our intensive management and observation. How do they present? So the clinical presentation may range from simple headache, mental confusion, dizziness, altered level of consciousness, depending upon the impact, the site involved, the brain involved, the presentation may differ. Then there may be vomiting, irritability, and it may progress to coma if the ICP raises. Pupillary abnormalities are commonly seen, changes in size, shape, and response to light. Sudden onset neurologic deficits are very common. Speech and visual disturbances, if the areas of brain, uh, corresponding areas are injured. And there may be altered vital parameters. So these patients may sometimes present with bradycardias, tachycardias, hypohypertension, depending upon the pattern of injury. When we are seeing this type of sign, so that's a complete black eye, raccoon eyes, and that's a battle sign. So we have to anticipate. If we see this, then we have to anticipate that these are the signs of base of skull fracture. Okay, and then we have to remember that nasal interventions may be dangerous in these patients, right? So coming to diagnosis, yes, clinical assessment is very important, GCS score and pupillary reaction. After this is done, the primary imaging, the main diagnosis depends upon the non-contrast CT and MRI. And these are few adjuncts which we do simultaneously. So how does all these different hematomas look on CT? The epidural hematoma, as we have seen, it is above the dura. So it looks like a lenticular shape. Then subdural hematoma, this looks like a crescent shape. Okay. Subarachnoid hemorrhage, it usually follows the pattern of your sulci and uh, fissures. In this intracerebral hematoma, you can see there is a little bit of intraventricular hemorrhage also. Okay, so depending upon the CT finding, actually the clinical presentation and the management varies. This is a patient of gunshot injury which has come to our this thing institute. You can see the trajectory of the this thing, and pneumocephalus can be seen, the contusions can be seen, and depressed fractures can be seen. So it can be a combination of multiple types of brain injury, or it can be a simple isolated brain injury. Okay. Whenever we are dealing with trauma patients, do not forget that head injury can be a part of polytrauma. So a patient, this is also another patient presented to our institute, a severe epidural hematoma with pneumothorax with fracture pelvis. So he was a bike rider and presented to our institute in polytrauma. So we have to remember and we have to carry forward a protocolized approach. So management principles depend upon we usually follow ATLS guidelines. Beautiful guidelines are given to handle these cases. Monitoring, I will be covering basic and advanced. In short, surgical interventions, medical management, anesthesia implications, and post-operative care. So coming to our ATLS protocol, everyone has to be well oriented about this because trauma is rising in India and it is the leading cause of death, as we all know. So rather than getting panic, actually trauma resuscitation rooms are actually, they are, if we do not follow certain guidelines, then everything may go haywire. Okay. So to avoid that, we have to do proper primary survey in the form of ABCDE, ongoing resuscitation, secondary survey, and definitive care. Okay. So airway maintenance is always with C-spine control. Dr. Pallavi has covered it really well. Breathing and ventilation, depending upon the type of injury, lung injury, involvement, fracture ribs, we have to decide. Circulation and hemorrhage control and resuscitation goes hand in hand. So even if it is a vertical approach, actually everything is happening at horizontal level. Disability, neurologic examination actually falls over here. Exposure and environmental control, that is temperature control and detailed log rolling and all those things come over here. Resuscitation we will be seeing, and secondary survey actually this is a time where you will be asking about the history and will be doing head to toe examination. Okay, and then comes the definitive care. So coming to airway management, even though Dr. Pallavi has covered it really well, specific to trauma, traumatic brain injury, let me tell you all that early definitive airway, if your patient has GCS of less than or equal to 8, or there is a loss of protective reflexes, securing definitive airway is very important. Assume cervical spine injury if it is not radiologically or clinically ruled out. Okay, so inline stabilization is mandatory whenever you are intubating this patient. Also, you have to assume that all these trauma patients are full stomach. So, rapid sequence induction is with gentle laryngoscopy is mandatory. Pre-oxygenation to avoid hypoxia is very, very important because that is the leading cause of cerebral injury. Prevent hypotension during inductions because this again is going to aggravate the secondary brain injury. So at receiving, when you are securing airways, having understanding about these principles is very important. So keep your fluids ready and keep your vasopresses ready. Blunting sympathetic response, many a times it may not be possible, but yes, if the patient is having hypertensive response, even in trauma resuscitation room, you may consider giving some opioids like fentanyl or lidocaine. Confirming the endotracheal tube with EtCO2 is must, and securing it is also very important because after you secure the tube, patient may be wheeled into CT or MRI, which is completely out of your area. So accidental extubations, endobronchial intubations, all sorts of problems we have witnessed. Avoid nasal intubation. I have discussed this if there is a anticipated fracture base of skull. So, as I said, that assume cervical spine injury. So, one of the patient had head injury, EDH with cervical spine injury, presented with bradycardia and hypotension. That's the manual inline stabilization being administered, and that's the cricoid pressure being added. So, these are the assisted intubations. You need 3 to 4 people to uh, have these kind of intubations, and suction and laryngoscopy is suction while doing laryngoscopy. The Salat technique which Dr. Pallavi mentioned is very, very important in trauma because if you are going to select video laryngoscope for your intubation, then your visibility is grossly going to get hampered if your suction is not working or patient is bleeding and the patient may have vomitus in this thing in the mouth. So having a good suction, working suction is very important. Choice of agents. Yes, if your patient is euvolemic, you may select propofol, but in hypovolemic patients, majority of the times we are selecting etomidate. There are few studies being done using ketamine in traumatic brain injuries, but without much complications, but it requires furthermore studies. About neuromuscular blocking agents, yes, suxamethonium we are using within first 24 hours intubations we are using, especially when we are anticipating difficult intubation in this dose. And but wherever we are seeing absolutely signs of herniation or raised ICP, there we are avoiding suxamethonium. It has to be avoided because, and along with head injury, if your patient also has documented hyperkalemia or crush injury, CKD patients, burns patients in their first after this thing, spine trauma patients, you are supposed to avoid that. Beautiful alternative drug, rocuronium is available, and with the availability of Sugamadex now, our job has become little easy in securing these airways in emergency. Let me tell you that yes, intubations in trauma receiving rooms are to be considered difficult intubations because of all these multiple factors. There may be facial fractures. We had an extensive, elaborate presentation just now. There may be oral bleeding. The airway itself may be disrupted. It is an emergency intubation. You cannot postpone it, right? And these patients are full stomach. So whenever you are securing airways for these head injury patients and unstable cervical spine patients, they cannot be only difficult, but they can be dangerous at times because the situation may be complicated by hypovolemic shock, and multiple unsuccessful attempts may lead to hypoxia and further airway injury, more so in pediatric patients. Okay. So the most experienced anesthesiologists should be available for dealing with these intubations. And again, in short, I'm just covering DAS guideline, combination of all these guidelines. Basically, when you are anticipating difficulty, anticipate and declare the difficulty early. So we have said that code D, activate it early so that you can get and call for you can call for help early, right? Oxygenation is priority all the time. So pre-oxygenation as well as para-oxygenation using nasal O2 by whichever means available. So nasal oxygen um, through your flow meter or your HFNO can be installed. Plan A in all these, whenever you are anticipating difficulty, video laryngoscope with bougie, mainly the blade portable video laryngoscopes are available. With bougie is the first choice. We are doing that, and limit attempts because that may lead to further desaturation and trauma, airway trauma. If this fails, then plan B is your second generation supraglottic airways, and failing which you can again try one more time face mask ventilation. But remember, while doing all these things, remember that your patient is full stomach. He has all the chances of aspiration pneumonitis, and that can further worsen the hypoxia, and it can lead to aspiration pneumonitis, and it can worsen the situation completely. Okay, so if all this fails, then declare complete ventilation failure early. So consider front of neck access early by cricothyroidotomy, and always confirm ventilation with 6 point wave capnography, which has been recently added in IDA. And securing these devices is very, very important. Coming to ventilation, wherever these patients we are maintaining, we usually should practice lung protective ventilation strategies, assuming that they may be having some lung contusion, fractured ribs, and there may be some aspiration pneumonitis, and neurogenic pulmonary edema has also been well documented. So, assuming all these things, anticipating all these things, lung protective strategies should be initiated right from the beginning. Mandatory ETCO2 monitoring, maintain normocapnia. So all these guidelines, BTF guidelines and ACS guidelines, TBI guidelines actually are recommending PaCO2 values between 35 to 45. Okay. Target SpO2 more than 94%. So avoid hypoxia. Again and again, I'm stressing on these because hypoxia and hypotension, these are the two important predictors for mortality. They have been found to be important predictors of mortality in all these patients in multiple studies. Avoid high PEEP because by increasing PEEP, you are decreasing venous return and you are increasing ICP further. Okay. So unless required, we do not give high PEEP in these patients. Avoid swings in PaCO2 during transport, during positioning, during induction. Okay. Hyperventilation, when we can give. So it is not a routine strategy anymore nowadays because low PaCO2 causes cerebral ischemia. We don't want that, right? So only for impending herniation, where we are, actually you are buying time till the definitive measures are taken care of, or till your osmotherapy works, or till the patient is posted for surgery. So for a very short duration of time, temporarily, you can maintain PaCO2 levels between 30 to 35, and it has to be immediately stopped once the ICP is controlled, right? So coming to circulation and resuscitation. In these patients, the systolic BP targets have been shifted from 90. The Brain Trauma Foundation actually has given very beautiful guidelines. 2007 guidelines had these targets of 90 mmHg as a systolic BP, but now it has been shifted to 100 to 110 mmHg. So just for the age group of 50 to 70, they have a target of 100, and below and above the target of 110 has been redefined because, as I said, it is the strongest predictor of mortality. Okay, and whenever you are managing or resuscitating these patients, keep in mind that you are not just targeting values, you are also keeping in mind the cerebral perfusion pressure. Okay, so the target for this is set as 60 to 70 whenever we are monitoring. Okay, control bleeding, which is very essential because in trauma, hypotension is equivalent to hemorrhage until proven otherwise. Okay, so yes, your patient has traumatic brain injury, but if he's bleeding actively, you have to control it first, right? Give isotonic crystalloids as in resuscitation fluid. Give blood if your patient is bleeding, and start noradrenaline early if your mean arterial pressure is falling below your targets. Avoid fluid overload in these patients because it may increase cerebral edema and it may lead to ARDS. So correct the contributors whenever you are doing resuscitation. Correct the contributors like anemia, hypoxia, acidosis, coagulopathy. If there is pneumothorax, then you need to simultaneously insert an IC. Okay. Coming to disability, rapid GCS assessment, documentation of baseline GCS, and monitoring it as a document as a trend is very important, because then only you will able to understand what is happening to the patient, whether he's improving or he's worsening. Pupillary size and reactivity, again asymmetry, mass effect, herniation, you will be able to identify this when there is an asymmetry. Assess for lateralizing signs, look for seizure activity, and you have to control this under any circumstances because a single seizure activity increases oxygen demand of brain, and which is not essential. It is which can be dangerous for these traumatic brain injury patients. Also identify the confounders, like majority of the patients, half of the patients, I can say, are under influence of alcohol when they are received in our receiving area. They may be under effects of multiple sedatives or multiple drug addictions is becoming, unfortunately, it is becoming very common in younger generation. Hypoxia, hypotension, hypoglycemia. So these three things needs to be corrected before you label that person as a neurological problem. So you have to correct hypoxia, hypotension, hypoglycemia, and then reassess the GCS and pupillary size and document it. Okay. Repeated assessment. So this comes under your secondary survey, right? So just to summarize, I have made this table in which ATLS, Brain Trauma Foundation, and ACS TBI recent guidelines have covered. So we can roughly see that intubate early, secure airway early in these patients because unprotected airway reflexes, we don't want all that. And these are all the targets for SpO2, SBP, PaCO2. ICP and CPP, yes, the targets have been given by both these are matching. The BTF and ECS TBI guidelines, both targets are matching. Coagulation, we will see in detail in upcoming slides. Okay. Coming to monitoring of these patients, the continuous ASA standard monitoring is important along with ETCO2, core temperature. Along with these, blood glucose monitoring target also has been set as 100 to 180 milligram per deciliter. Earlier studies, they have taken there have been certain studies of tight control, but they did not find any promising results. Rather, the chances of hypoglycemic episodes were very high. So we are following these targets for blood sugar. Monitoring of urine output and catheterizing these patients. Many times I have seen that patients are on osmotherapy and they are not catheterized. It may so happen because your trauma ward is so busy. So following a protocol, following adjuncts to your primary survey and secondary survey is very important. Serial neurological examination and APG analysis to determine oxygenation, ventilation, acid base, and along with this, you do get an electrolyte monitoring also. Coming to advanced management, yes, as in severe TBI, the invasive arterial pressure monitoring is important to measure mean arterial pressure, to document the CPP. Intracranial pressure wherever possible and wherever the facility is available, is to be monitored in severe TBI cases with abnormal CT findings. Brain tissue oxygenation, jugular venous oxygen, these are all advanced monitoring techniques. I'm not going into details of it, but yes, they do help in management of these patients, and prognosis may be determined and the management may be altered depending upon the values. Okay, coming to ICP monitoring, yes, level 2, level 3 incidence, level 2, level 3 evidence is there. So all patients with severe traumatic brain injury with abnormal CT findings, you should be monitoring ICP. And patients with normal CT, severe TBI with normal CT. But if your patient has two of these factors like age more than 40 or unilateral or bilateral motor posturing or systolic BP is less than 90, then you're supposed to monitor ICP. These are the different modalities by which we can monitor it: subdural bolt, subdural catheter, epidural transducer, intraparenchymal fiber optic catheters, and ventriculostomy. By having ventriculostomy, you can actually drain the CSF, so it can work not only as a diagnostic tool, but it can work as a therapeutic tool also. So whenever you are anticipating or patient has raised ICP, right? So that's the toolbox we usually follow. So head up position, simple. These are actually very simple techniques, but they are difficult to follow in ICU, especially if your ICU is very heavy. Okay, so maintaining these patients in 30-degree, 20-degree head up position once they are hemodynamically stable. Neutral positioning of the neck is very important to facilitate the venous drainage from head and neck. Sedation and analgesia, normocapnia, osmotherapy, and treating fever and seizure is very important. So this is a tiered approach. So tier 0, tier 1, tier 2, tier 3, we can see this is the basic care which all the patients should receive. So oxygenation, normocapnia, analgesia, this is the basic care all head injury patients should receive. Tier 1, if your ICP is rising, then try with osmotherapy, hypertonic saline or mannitol, CSF drainage if EVD is present. Tier 2 is optimized ventilation, monitor CPP, optimize CPP, neuromuscular blockade may be instituted, and mild hyperventilation, short-term hyperventilation will be tried. And tier 2 is, this is just a rescue therapy. So barbiturate coma and decompressive craniectomy. Okay. So now coming to which all are the patients who are going to require surgery. Okay, as an anesthesiologist or intensive care specialist, we should know about these details. So patients with EDH, SDH with mass effect, deteriorating GCS, unequal pupils, and raised signs of ICP. Okay, these are the patients who are going to require uh, surgery, and you need to anticipate and prepare these patients so that they can be, you minimize the delay and they can be rapidly transported to the operation theater. Progressive, this is a CT, you can see progressive increase in midline shift. So any midline shift above 5 mm, they say, you should be watchful, and these are actually the indications when you are going to call the neurosurgery. So EDH, any EDH above 30 ml, SDH more than 10 mm in thickness, and midline shift of more than or equal to 5 mm. Okay. Refractory ICP, if you are monitoring ICP, then refractory raised ICP above 22 mmHg may also require surgical interventions. And again, the penetrating brain injury, CSF leaks, mass effect lesions, they may require these surgeries. So this is a CT showing normal brain and raised ICP. Normal brain, these are the ventricles, these are the sulci gyri, you can see properly. And in edematous brain with signs of herniation, the ventricles will be compromised, will be compressed, they will be slit-like, and you will not be able to see the differentiation of the sulci and gyri. So there will be diffuse cerebral edema, right? So what all are the interventions which are routinely done for these patients? The craniotomies, evacuations, decompression craniectomy, EVDs can be inserted, and depression, elevation of depressed skull fractures, dural repels, all these things are done. Okay. Coming to medical management. So while we saw the initial management as per ATLS, we understood what all patients are going to require surgery. Hand in hand, the medical management has to be uh, has to be carried forward. Okay, so which IV fluids to give? Sugar control we have discussed, anticonvulsants, barbiturates. So I will be discussing all these things in short. Fluids in TBI, yes, isotonic crystalloids are the first line of treatment. So 0.9% normal saline and balanced salt solutions can be given. When you are giving only 0.9% normal saline, be watchful about hyperchloremic acidosis. Hyperchloremic, hypernatremic acidosis can happen. Okay, so you need to monitor electrolytes in these patients. So goal here of giving this thing is euvolemia, and at the same time you are avoiding fluid overload. About colloids and hypertonic salines, a big no to hypertonic salines. So all your dextrose containing D5 or half NS, unless indicated, we are not going to give this. These are going to increase cerebral edema, right? Albumin, there have been studies in which it has been found out that it increases the mortality in traumatic brain injuries. So controversial results have been found, and it requires more studies. Synthetic colloids, again, have been found to have coagulopathy and AKI, so we are not actually using them. Hypertonic saline and mannitol, yes, it is to be used for ICP control, but not as a routine fluid, right? These are the blood sugar targets. So 100 to 180 we are millimeter per deciliter we are using, and we are no more using tight control. Hyperglycemia and hypoglycemia both can be detrimental for these patients. One, hyperglycemia may increase cerebral edema, increase risk of infection, and worsen the neurologic outcome. And hypoglycemia may at times cause seizures, direct neuronal injuries, and we have to be watchful about hypoglycemia, especially when you are treating pediatric head injury patients, right? Anticonvulsants, yes, mainly we are using phenytoin and levetiracetam, loading dose followed by maintenance dose, depending upon the requirement. Coagulation, coming to coagulation. So trauma, we all are well versed with trauma-induced coagulopathy, but chances of coagulopathy in traumatic brain injury are also, the incidence is also very high. So reversing anticoagulants in these patients, if the patients are on anticoagulants, you need to reverse it because it is going to increase bleeding. Platelet thresholds for TBI has been aimed to, actually guidelines are saying more than 75,000 per deciliter, but many neurosurgeons and even our center, we are following platelet count of more than 1 lakh before neurosurgical intervention. Hemoglobin target of 7 to 9. Tranexamic acid has a promising result if given 1 gram given in first 3 hours of injury. So these are actually the anticoagulants. So mainly these patients may require, depending upon the values, the either platelets, FFPs, vitamin K, prothrombin complex concentrates. So depending upon what anticoagulant this patient on, whether he's on antiplatelets or anticoagulant, you are supposed to reverse it with appropriate agent, right? This is a beautiful study done with respect to tranexamic acid in trauma, CRASH 2 and CRASH 3 study. CRASH 2 study was done in large number of, both studies are a large number of patients, had a large number of patients with multicentric studies. CRASH 3 study was specifically conducted in traumatic brain injury, and what they found is whenever tranexamic acid 1 gram followed by 1 gram bolus over 10 minutes followed by 1 gram over 8 hours infusion, when it was given within 3 hours of trauma, it was found to be safe and it was found to reduce head injury related mortality, especially in mild to moderate cases. And no significant thrombotic events were observed. So this we are practicing routinely in our trauma ward. Coming to osmotherapy, whenever the patient has raised ICP, giving osmotherapy is essential. So mannitol and hypertonic saline can be given. And usually we are giving hypertonic saline in pediatric head injuries. We need to monitor, whenever we are giving hypertonic saline, we need to monitor serum sodium levels 6 hourly, because many a times the serum sodium levels starts rising, and to our experience, we have seen that many patients do exhibit metabolic acidosis also. So fluid management, electrolyte management has to be very meticulous when we are using osmotherapy, right? Uh, Before giving mannitol, we have to ensure that patient is euvolemic and avoid mannitol if patient is hypotensive or patient is already having deranged renal function test. Okay, so in patients who are in shock or hypotension, you may use hypertonic saline. Okay, coming to hypertensive treatment. So, when are we going to treat hypertension? Yes, not all patients present with hypotension, right? There are some patients like SAH, already hypertensive patients, old age patients, they do present with hypertension. So whenever the systolic BP is more than 160 or 180 with rising ICP and risk of bleeding, there we are treating hypertension. The first line of agents which we are using is labetalol, nicardipine, ismolol, depending upon the situation. And nitroprusside and NTG is usually avoided in traumatic brain injury for the risk of cerebral vasodilatation. Okay, whatever drug you are choosing, please remember that sudden fall in BP is not uh, advisable. So titrate your drug slowly, preferably have arterial line in place, and then monitor. Then only give these drugs. Coming to analgesia and sedation in these patients. So analgesia first, because we are routinely using fentanyl in our trauma patients to control pain, because that is very essential, one of the modality to manage your ICP, right? But be watchful when you are giving doses. Give slow titrated doses. It should not lead to hypotension. Same goes true with sedation. We are targeting a RAS sedation score of -2 to -3. Deep sedation is not indicated in these patients, and propofol and dexmedetomidine can be used in these patients because both of them reduce cerebral metabolic uh, oxygen demand and ICP. However, be watchful that both these drugs can lead to bradycardia and hypotension. So we have to be extremely careful and titrate the drug and dose depending upon the patient's physiology. Avoid larger boluses of benzodiazepines. Antibiotics and daily sedation breaks are actually recommended in these patients. So coming to anesthesia implications, pre-operative phase, we have actually seen all the targets, and so stabilized physiology is very important before transferring the patient to OT. Many times it is ongoing resuscitation and some EDH patients, because they do present to us in GCS 15 in lucid interval and suddenly they deteriorate, and we have to wheel in the patient to OT. Yes, but during that time also having a detailed knowledge about physiology and managing and maintaining physiological parameters is our target. Rapid neurological assessment, quick review of CT scans is important to identify what exactly is happening inside the brain. Then only you will be able to titrate your anesthesia, right? Like suppose with patient is having major mass effect or midline shifts, then you know which are the patients who are going to crash at induction, and you will be well prepared well in advance. Check all the laboratory investigations which are available. Check for ECG, X-ray, because many of these patients do have electrolyte abnormalities, hyperkalemia, hypocalcemia, hypernatremia, hyponatremia. All the combination of electrolyte abnormalities may be present, and they may have their manifestation of ECG. Confirming blood and blood product availability is very important. C-spine protection, having your difficult airway plan and cart and equipment, appropriate size as per patient's age, weight is very essential. IV access, we secure to a large wide bore IV access, but yes, art line and central venous access, mainly subclavian veins we are securing for patients who are severe traumatic brain injury, who are going to require prolonged ICU care, who are going to require vasopressors, mannitol. Again, it requires central venous access. Okay, so keep your vasopressors ready at induction, anticipating the uh, hypotension. Optimization of the comorbidity, actually we don't have much time to optimize, but yes, in certain cases of chronic SDH, they do come after some time. We do have some time to optimize, and you should be trying to do. Coming to anesthesia drug choices, we have discussed this about the induction choices and opioids and muscle relaxants. Maintenance, propofol infusion can be preferred. It gives very good ICP control. And inhalational agents in lower doses, less than 1 mAh, sevoflurane over isoflurane, desflurane are acceptable, but avoid higher MAC levels because it leads to cerebral vasodilatation. Nitrous oxide usually we avoid because it has a risk of increasing cerebral blood flow and ICP. And especially in patients with pneumocephalus, pneumothorax, all these patients, it is absolutely contraindicated. Okay, so coming to multimodal analgesia options, we should be giving these options to all our patients: fentanyl, tramadol, paracetamol, and scalp blocks wherever indicated and wherever possible. We can use scalp blocks using ropivacaine or levobupivacaine or bupivacaine. Intraoperative, what problems can happen? So actually these patients may have hypotension, blood loss, acidosis, coagulopathy, hypothermia. That's our lethal triad: acidosis, coagulopathy, and hypothermia. The one worsening the other two. Okay, so treating these, continuing the treatment from your preoperative area to intraoperative area to your postoperative ICU is very important. Arrhythmias, yes, intraoperatively, these patients do have tachy or bradyarrhythmias. Sudden cardiac arrest also may happen if there is an herniation on table. And, while doing these cases, a constant communication with your neurosurgeon and with your team is very important. How tense the brain is, whether brain is pulsatile, how much is the blood loss, because especially in pediatric patients, the blood loss may be a very significant problem, because scalp being very vascular. We have seen many pediatric patients with hemoglobin of 5 and 6, and we have induced those cases keeping blood in hand or waiting for blood. So, uh, all these problems we have to keep in mind. And last but not the least, our awareness under anesthesia, because trauma has because of our focus is on resuscitation and maintaining the hemodynamics, the awareness is sometimes it may get neglected. So monitoring the patients for this is very indicated in these patients. Intraoperative targets, these are the intraoperative targets. So ventilation targets and saturation, we have to continue. Hemodynamics, brain relaxation techniques, again, we have to continue perioperatively. Temperature and normothermia is nowadays recommended. No more hypothermia is recommended by various guidelines. Anticipate blood loss and platelet count above 1 lakh is indicated for patients undergoing neurosurgery. Massive transfusion protocol, if your patient also has other injuries, occult injuries, or patient is bleeding and you have activated the massive transfusion protocol, then 1:1:1. We usually follow this ratio in our institute. There are various different ratios available. Depending upon the availability of blood and blood products, we are supposed to carry forward this. So whenever now coming to emergence and transfer and ICU handover, avoiding the third hit is very important. So whenever the surgery is done, smooth emergence from anesthesia is very important. Prevent any coughing, bucking, agitation, hypertensive responses, even at extubation. Tube kinking, anything which is increasing the peak airway pressure is not indicated, and especially this can happen in this stage. Extubate only if it is safe. Otherwise, majority of the patients of severe traumatic brain injury, they go in ICU on a ventilatory management. Maintain targets. Structured handover, detailed handover to your ICU team is very important because it is an ongoing process. Sedation and analgesia, seizure prophylaxis, and ICP, CPP monitoring is to be continued in postoperative period, and keep low threshold for repeat CT if any neurological changes or damage or is observed in immediate post-operative care. So coming to post-operative ICU care, we do continue with analgesia, ventilation, hemodynamic supports, antibiotics, everything is continuing, but special mention on nutrition support is very important. So day 3 to day 4, we do start with our nutritional support for these patients. Physiotherapy, active and passive physiotherapy, very important because these are the patients who are immobilized many a times. So proper positioning, frequent change of position is very important. Similarly, DVT prophylaxis. Majority of the times we are unable to give pharmacological DVT prophylaxis in these patients. So mechanical DVT stockings or compression devices is must in these patients. And lastly, stress ulcer prophylaxis. So coming to special population, I'm not going into details of it, but we have to remember we do get patients in all these uh, category. Pregnant patients with head injury, motorbike accidents, or whenever they present to you, you have to know that there is an altered physiology. They may tolerate initially greater blood loss, but it is at the cost of maternal and fetal problems. Radiological investigations, when you are doing, you have to be careful about whether if the female is in that childbearing age group or she is pregnant, then you have to be watchful about that. Fetal monitoring, whenever we are dealing with these patients in your ICU, is to be done. So having a multidisciplinary approach involving gynecologists in the care is also important. Pediatric patients, we do keep getting lot of pediatric head injury patients, fall from height, fall from staircase, and they do come up with severe head injury. Many a times nowadays we have started getting patients intubated outside and coming. So whenever they are coming, please remember that they are having all the principles of our pediatric anesthesia we have to keep in mind. They do have low functional reserve. They are very prone for hypoxia. If they have been intubated somewhere outside, many a times the size of the tube is so mismatched that you have to change the tubes, but subsequent intubations are difficult because of airway edema. So these practical points, they desaturate very fast. They don't give you much time. Slightest amount of blood clot or secretions blocks the tube and ventilation becomes challenging. So they have very poor tolerance to blood loss, prone for occult internal injuries. So mainly injuries to hollow organs as well as solid organs. Duodenal perforations, pancreatic injuries, splenic liver lacerations, all these things are also there in these patients. Elderly patients, again, they come with their set of problems, but please remember that they will be on polypharmacy, antiplatelets, anticoagulants. Assessment may be misleading initially if they are on beta blockers because compensatory mechanisms for the shock may be absent. So they may appear stable, but actually they may be intravascularly, there will be a hypoperfusion. Okay. So having consideration about these special situations is very important. So my take home from my experiences, secondary as an anesthesiologist, what is preventable is secondary brain injury. And we have to work in this direction together as a team. Physiology determines outcome more than drugs in TBI. Use right fluids for resuscitation and even in perioperative management. Individualize the choice of anesthesia as per patient's needs. Airway and induction may be critical moments wherein, hypoxia and hypotension, even the single episode of hypoxia or hypotension can be detrimental. So prepare well, anticipate and prevent complications. And anesthesiologists actually are the outcome modifiers in traumatic brain injury. So as a member of this community, yes, we do have a very responsible role whenever we are handling these traumatic brain injuries, and the outcome is really well when you act in time. So, thank you so much. Thank you once again for this opportunity.